Hi everyone. Today we will be discussing about juvenile nasopharyngeal angiofibroma, part 3, the final part of juvenile nasopharyngeal angiofibroma. Okay. So the first we are going to discuss under the following headings: the treatment, what are the surgical approaches, what is the role of medical therapy, and what is the prognosis of this disease. Okay. Now, coming to treatment, surgical excision is the treatment of choice. Surgical excision is the treatment of choice. There is no medical therapy for juvenile nasopharyngeal angiofibroma, meaning that we don't have a modality of treatment which can reduce the disease, which can remove the disease by using a therapy, either hormonal or radiotherapy or chemotherapy. So, surgical excision of juvenile nasopharyngeal angiofibroma is the treatment of choice. Okay, before we remove the tumor, we need to do preoperative embolization for every case of juvenile nasopharyngeal angiofibroma. So preoperative embolization is done mainly to the feeding vessel. Most commonly, it is the maxillary artery, which we have seen, which is a branch of the external carotid artery, which enters into the spinopalatine fossa. Okay, we use reabsorbable microparticulate particles. This is just, you have to, it's not needed to remember it, but we do preoperative embolization of the feeding vessel before the surgery. It is an important step before you take up the patient for surgery, and it has to be done very recently. Like, you have to do it one day before the surgery, so that alternative blood vessels do not form. Anastomosis does not occur. Okay, we can use what are the materials we can use for preoperative embolization? We can either use gel foam or dextran microspheres. Okay, now coming to surgical approaches, depending on the extension of the tumor, depending on how much the tumor has extended from its origin, we decide the surgical approach. Okay, surgical approaches, we have various surgical approaches. I want you to understand that suppose there is Hyderabad city. This Hyderabad can be reached by the north side, the south side, the east side, or the west side. These four things: north, south, east, west. These are the approaches. We are approaching the same city by various methods from various directions, if you may. Okay, if the tumor is confined to the nasopharynx, so the tumor is confined to the nasopharynx, it has not extended much into the spinopalatine fossa, not into the infratemporal fossa, then we can either go by the endoscopic transnasal approach. So you are using an endoscope, there is no incision on the skin, we are directly going into the nasopharynx area. We will elevate the mucosa at the region of the spinopalatine foramen, and we are going to remove it. If preoperatively we have confirmed that the tumor has not extended into the spinopalatine fossa, and it is easy to remove the tumor from the nasopharynx and the posterior part of the nasal cavity. Suppose we are not confident that we may be able to remove it with the help of an endoscope, we can go with a transpalatine approach. Now, shortly we are going to talk about what is transpalatine approach. Suppose a tumor is extending from the nasopharynx into the cheek, we use transpalatine approach plus sublabial approach. This is called Sardana's approach. So you are approaching the tumor which is present from the nasopharynx, extending a little bit into the cheek, we use a bigger incision. Okay, transpalatine is only for the nasopharynx. So from the nasopharynx, you can, if the tumor is extending into the nasopharynx, transpalatine is good enough. But if it is extending into the cheek, it means what? The tumor is there in the nasopharynx, nasal cavity, it is there in the spinopalatine fossa, and it has extended into the infratemporal fossa. So this is quite a big extension. We know, right, the staging of the tumor. If the tumor has extended into the infratemporal fossa, it is stage 2C, right? So if transpalatine is not enough when the tumor has extended into the cheek, Okay, suppose the tumor is there only in the sphenopalatine fossa, extension into the sphenopalatine fossa. We can either approach it by the lateral rhinotomy approach or the midfacial degloving approach. So these are the two approaches from where we can reach the area where there is a disease, where there is a tumor. Then either we do a midfacial degloving or lateral rhinotomy. Thing will be to perform a medial maxillectomy, removing the medial wall of the maxilla, which forms the medial wall of the maxillary sinus. From there, we can easily remove the posterior wall of the maxillary sinus and reach the sphenopalatine fossa. Okay. So suppose the tumor is there only in the maxillary sinus and in the sphenopalatine fossa. So there is not much extension into the cheek. We can use the transmaxillary approach, also called the Caldwell-Luck approach. So if the tumor is there only in the maxillary sinus and the sphenopalatine, we can perform the transmaxillary approach, also called the Caldwell-Luck approach. Now the final thing is that the large lateral extension into the infratemporal fossa. We use the infratemporal fossa approach, which is a larger incision and a more it's a larger incision and causes more morbidity to the patient. Okay, as the size of the incision increases, as we are going through multiple approaches, the morbidity to the patient increases. The best way, if the tumor is small enough, if the patient has come early, the best way is obviously the endoscopic transnasal approach, where we are not giving any incision, patient is going to come out of it very easily. But also we should remember that this tumor extends into all the crevices of the sphenopalatine fossa. So there is a chance that you may leave the tumor behind and there is a chance for recurrence. Okay. Now coming to the surgical approaches proper. Each surgical approach, let us describe it a little bit, not in detail, not in too much detail. So what is transpalatine approach? Suppose this is the palate, this is the hard palate, this is the soft palate. Okay. So if you do an incision in between the hard palate and the soft palate, and you nibble a little bit of bone of the hard palate, then you can reach into the nasopharynx. This is what they have done. This is the soft palate, it has gone this side. This is the hard palate. They have probably removed a little bit of the hard palate, so you can reach the nasopharynx area, posterior part of the nasal cavity, nasopharynx area, through the transpalatine approach. As we have already talked about, transpalatine approach is where we do it when the tumor is confined to the nasopharynx. Here, the incision is given between the hard and the soft palate. Sublabial approach, if you can appreciate here, these are the teeth. Okay, we are going into the oral cavity, and from there we are trying to reach the nasopharynx. This is the sublabial approach. Here, if the tumor from the nasopharynx has extended into the cheek, we go for the sublabial approach. So here the incision is given under the lips, and from there they have gone into the nasal cavity. I guess here we have already removed the medial wall of the maxilla, so that a good approach to the sphenopalatine fossa has been achieved. So medial maxillectomy, you can call this an approach, but basically this is a removal of a part of the a step of the surgery. Here the medial wall of the maxilla is removed. You can appreciate here, this is the orbit. Okay, this is the orbit on the right side. This is the inferior turbinate on the left side. The right side, there is no inferior turbinate. You can see the floor of the orbit. You can see the lateral wall of the maxillary sinus. You can see the floor of the maxillary sinus, but there is nothing here. The medial wall of the maxillary sinus, of the wall of the maxilla, that is the medial wall of the maxillary sinus, has been removed. By this, we can very well reach into the posterior wall of the maxillary sinus, from there into the sphenopalatine fossa. So this will give you more space to work around. Okay, now coming to lateral rhinotomy approach. Lateral rhinotomy approach is where now the first three incisions that we talked about, first one actually, the transpalatine approach and the sublabial approach, we are not making any incision on the skin. Here in the lateral rhinotomy approach, we are making a facial crease, skin crease incision along the lateral, along the bridge of along the lateral wall of the nose, where the nose is for joining the cheek, and along the ala of the nose and the frenulum, between in the midline of the lip, frenulum of the lip. Okay, so by this incision we can reach the medial wall of the maxilla. From there we go to remove the medial wall of the maxilla. Medial maxillectomy will be done, and from there we are going to reach the sphenopalatine fossa. So here the incision is made in the skin. So there is a skin incision in this case. Okay, there is a skin incision in this case. Midfacial degloving approach. Midfacial degloving approach, here there is no skin incision. This is the benefit of this surgery. There is no skin incision. Here an incision is made from one molar to the other molar. Okay, and then this upper part of the flap is raised. Upper part of the flap is raised up till the upper border of the piriform aperture, and from there we can reach the medial wall of the maxilla and the nasopharynx area. Okay. As I said, the benefit is there is no scar or of incision on the face. Transmaxillary approach we have already talked about initially. It is called the Caldwell-Luck approach. So here you are removing the anterior wall of the maxillary sinus. This is the lateral rhinotomy incision that has been made. Lateral rhinotomy incision to expose the anterior wall of the maxillary sinus. You can see the tumor here, and the tumor is removed. You remove the posterior wall of the maxillary sinus, and the tumor is removed. This is also called the Caldwell-Luck approach. Infratemporal fossa approach. Infratemporal fossa approach, this is a larger incision. It is much more morbid to the patient. Here an incision is given almost from the top of the skull in front of the pinna going to the neck. So this is in cases only when the tumor has a large lateral extension into the infratemporal fossa. So you have, this is called the infratemporal fossa approach. Okay, the eighth one, the last one, is the endoscopic transnasal approach. It is for diseases which are confined to the nasopharynx, and there is not much extension into the spinopalatine fossa or into the infratemporal fossa. So these are the various approaches. We will just have a revision of this. The first one is the transpalatine approach, where you are giving an incision between the hard palate and the soft palate. This is the tumor. If the tumor is confined to the nasopharynx. Sublabial, when we are giving an incision on the just under the lips to reach the anterior wall of the maxilla when the tumor is confined to the nasopharynx and the cheek. Medial maxillectomy. What is medial maxillectomy? We remove the medial wall of the maxilla so that we can reach the posterior wall of the maxilla and remove the tumor. Others are the lateral rhinotomy approach, midfacial degloving approach. Lateral rhinotomy approach, we are giving the skin incision. In the midfacial degloving approach, there is no skin incision. Transmaxillary approach, there is a lateral rhinotomy approach has been done. We can do it by sublabial approach also. Then the infratemporal fossa approach, when there is a large tumor, the tumor has a large lateral extension into the infratemporal fossa, we give a very large incision starting from top of the skull to the preauricular area into the neck, so that the entire infratemporal fossa can be clearly visualized and the tumor can be removed in its entirety. The best approach for the patient and for less morbidity is when the disease is confined to the nasopharynx. We can use an endoscope, and we can remove. Here you can see this is the septum. This is the left side of the patient. This is the middle turbinate. The sphenoid sinus is here. The ethmoids have been totally removed. The middle turbinate, the inferior turbinate has been removed. We can directly see the interior of the maxillary sinus. So the medial wall of the maxilla also has been removed. And here a lot of cauterization has been done. You can see this black part, the cauterization has been done to stop the bleeding. Okay, now coming to medical therapy. Medical therapy has very little role to play. Usually we do not go for medical therapy. Why? Because of the potential side effects. Medical therapy is a non-useful modality in most cases. Most of the cases we cannot use medical therapy as the first line of treatment. It is usually as an adjunctive treatment. What do you mean by adjunctive treatment? Adjunctive means when it is added to something as a supplement, not as an essential part. This is adjunctive treatment. When the main treatment is surgical, then the medical therapy here becomes an adjunct. So it is added to improve the results sometimes. Okay, radiotherapy. Radiotherapy is indicated in two situations. Basically, we do not prefer radiotherapy in this case because one is if you do radiotherapy in such a young child, as the child grows up into a young adult or into 40s and 50s, he may develop carcinoma. That is one of the reasons why we do not prefer. But when the tumor is in stage 3, that is, there is already an intracranial extension. Okay, when there is already an intracranial extension and it is deriving its blood supply from the intracranial vessels, it becomes basically unresectable. Okay, you cannot remove it anymore because it has gone into the brain and it is getting its blood supply from the intracranial blood vessels, then radiotherapy is indicated. And also in recurrent cases, if the radiotherapy is not given as a usual treatment, okay, when we do a surgery in a case of carcinoma larynx or something, if we remove the tumor completely, stage 3 or something like that, and we feel that the little bit of tumor is left over, and also as protocol of the treatment, we give radiotherapy. But here in this case, because it's a benign tumor, we do not give radiotherapy routinely in these cases. But in recurrent cases, you do think of radiotherapy. Hormonal therapy. Recurrent cases also, we go for surgery only most of the cases. Sometimes we may go for radiotherapy. Hormonal therapy has been proposed as one of the treatments to reduce the vascularity of the tumor preoperatively. One is diethylstilbestrol, which is a synthetic estrogen, and flutamide, which is a testosterone receptor blocker. We had talked about this in the etiopathogenesis, saying that because the tumor is seen exclusively in the males in the second decade, so it may be testosterone dependent. So we are trying to give a testosterone receptor blocker such as flutamide, hoping that it will reduce the vascularity of the tumor. It is not done routinely. Okay. Coming to chemotherapy. Chemotherapy also, it is reserved for recurrent and residual lesions. We can give doxorubicin or vincristine or dacarbazine. These are the various chemotherapeutic agents which are given either alone or in combination. Okay, so we can give doxorubicin, vincristine, and dacarbazine in recurrent and residual lesions. Okay. So what are the medical therapy? One is radiotherapy we talked about, the other is the hormonal therapy, and the third one is the chemotherapy. So these are the three modalities of medical therapy available should we need it in cases of recurrent and residual lesions. Okay, but the side effects are high, so we avoid it as much as possible. Okay, what is the prognosis of this case? The recurrence rate of the tumor is very, very high. We can say it's quite high. Most of the tumors do recur. So regular follow-up is one of the things that we do, a regular follow-up, and then if the tumor recurs and if it is small in size, we can do repeat surgery. Okay, so the recurrence, we should explain to the patient that the recurrence rate of the tumor is very high, because as we have seen, this spinopalatine fossa is an area which is very difficult to reach, and also it is having multiple extensions. So suppose there is a foramen rotundum, there is the foramen for the pterygoid canal, there is a optic going to the orbit, infraorbital fissure, and there is the palatine foramen through which the greater palatine artery. So there are multiple foramina also there, and also to reach it is quite difficult. So you can never be sure that you have removed the tumor in its entirety. So because of that, the recurrence rate of the tumor is quite high. So thank you for the patient listening. With this, we come to the end of the chapter of juvenile nasopharyngeal angiofibroma. Hope you have enjoyed listening to this class. If you find this useful, please do like and subscribe. Thank you.